Okay, so I'll sort of take over after what happens when there's a diagnosis. And so the things I'm going to cover is primary treatment of melanoma, management of a positive sentinel lymph node, and then talk a little bit about the multidisciplinary approach we're taking for some of our locally advanced melanomas. So I have a case presentation that'll go all the way through. So this is a 55-year-old female who presents with a changing mole on her back. She was biopsied by her dermatologist. It showed melanoma, a Breslow thickness of 2.0. This is an intermediate thickness melanoma with no ulceration. And she was referred to surgery for management. And so wide local excision always is a part of that treatment. It's the piece that really minimizes that local recurrence. But the question is really, how wide does wide need to be? And so, back before I was practicing, wide really meant 4-centimeter margins, which you can imagine if you look at that popsicle stick, that's over half of the popsicle stick as a divot in somebody's skin. There was a number of studies that looked at either 1 versus 3, 2 versus 4-centimeter margins. And the one that I highlighted here is the US study, which is the intergroup melanoma surgical trial. That compared 2 versus 4-centimeter margins. And what we can see on the screen, this is the rate of local recurrence between the two arms, which are essentially the same. And this was one example of the trials that demonstrated those wider margins of 4 centimeters aren't really necessary. And so 2-centimeter margins became the standard for most of our patients. The thing that's hard is that 2-centimeter margins, depending on where it is on the body, can still be tricky to close. So this is an example of someone who was closed with an ellipse, so kind of like that football shape excision that's pulled together. You can see that scars widen. There's kind of those railroad scars. I mean, that is probably our best case. Up to a third of people end up with some sort of local rotational flap or a skin graft to get it to close. And as you get more complicated, there's a higher risk of wound complications. So this question of whether we really need to even have 2-centimeter margins is being addressed in the Melmar 2 study, which is an ongoing clinical trial, which took patients who have intermediate thickness melanoma, so those patients for who 2-centimeter margins is the standard, and are randomizing them to get 1-centimeter margin versus 2. The primary outcome is 5-year disease-free survival. This includes both local recurrence, distant recurrence, all sort of melanoma events. They're also looking at specifically local recurrence, overall survival, quality of life, and surgical complications. This study has either completed accrual or almost completed accrual, and we have an estimated primary completion date of the end of 2029. So we need that 5-year outcome data, so it takes a little bit of time. I think this study is a really good example of a trial that has the potential to absolutely impact what our standard of care is. So everyone in this red are the people who currently get 2-centimeter margins. So depending on the results of the study, we could change what we're offering for care for probably a substantial portion of our patients with melanoma. So to continue our case presentation, she did meet with the surgeon, planned the 2-centimeter margin, which is the current norm. The lymph nodes were examined clinically. They all looked normal. And so the question is a clinical exam enough, or do we need to look more? And that's really where we talk about the Sentinel Lymph Node Biopsy. And the idea is that even if the lymph nodes feel normal, there's always a chance that there's something microscopic there. When we do the Sentinel Lymph Node, we inject a radioactive tracer or blue dye right around the site of the biopsy. Those dyes get taken up into the lymphatics, and they travel to the first lymph nodes that area of the skin would drain to. If the melanoma was going to spread, that's the same pathway it would take. These are the lymph nodes that would be most at risk. We have a handheld kind of Geiger counter. We look for anything that's hot, anything that's blue, and we take those out. So those are the sentinel lymph nodes. And when we think about why those matter, the first is that it's really prognostic. So if you have something in the sentinel lymph node, you're at much higher risk of having a future melanoma event than if that lymph node is clear. When we find something and we know that someone's at higher risk, that's when we start to think about doing more imaging. It changes our surveillance. It changes kind of whether we get PET CT or CT, kind of whole body imaging. It's also when we start to think about other treatments, so things like immunotherapy that we'll talk about in the later sessions. Historically, the sentinel lymph nodes are those first lymph nodes that drain from the melanoma or from the primary skin site, but it doesn't tell us anything about the rest of the lymph nodes in that lymph node basin. And so historically, the only way we could find out if there's anything else in that lymph node basin is to do a full lymph node surgery. And by far, the benefit is that we know with confidence that if there's anything else in that lymph node basin, we've taken it out. There's obviously some downsides. So almost always it's a second surgery, more discomfort. There's drains that are in place, range of motion that we have to work on, but lymphedema is really the thing that we worry about most. And that's probably 20 to 40%, depending on whether it's neck or armpit or groin. So the MSLT2 clinical trial really was trying to address this question of, do we need to do the completion lymph node dissection for everybody? They took patients that had a positive sentinel lymph node, so people who we found the lymph node and there was a little spot of melanoma in it, and then those patients got randomized to either the completion lymph node dissection or this extra close observation. And that's with not just clinical exams, but using ultrasounds. So this is an example of what a normal lymph node looks like by ultrasound. So it kind of has a little kidney bean shape. That black part is the outer cortex. Inside that circle, that's the fatty hilum. This is what a normal lymph node looks like. And the idea is that when there's any melanoma in a lymph node, that morphology, that architecture will change long before you can feel it clinically. And this is just an example of a lymph node that did have cancer in it, where that cortex starts to get much thicker. It doesn't quite have that kidney bean shape anymore. It's starting to get more rounded. And these are the kinds of things that we're looking for when we're doing the serial ultrasounds to say, hey, this is someone who maybe we should biopsy it. Maybe this is someone who has melanoma in that lymph node basin. So the MSLT2 study compared those two arms, people who had surgery right away and people who only had surgery if something progressed. And at their 10-year outcome, there was no difference in survival. And I think probably one of the things that I talk the most about is that 75% of people in that observation arm never ended up needing that lymph node surgery. So they were spared all the morbidity of what happens with the lymph node dissection because they never had anything develop there. The 25% of people who ended up having something progress and went on to have that lymph node surgery, I think we can have confidence that we're not hurting them oncologically. Like the cancer outcomes are the same as if we had done it up front. So I think this was a really big advance and is really reflected in our current standards. Looking at patients who have sentinel lymph node positive disease, the NCCN guidelines absolutely recommend active nodal based ultrasound or other sort of imaging surveillance as the standard, as opposed to completion dissections for everybody up front. So to continue our case presentation, she had a wide local excision, had the 2-centimeter margins, had a sentinel lymph node biopsy, which was found to be positive, and was followed with MSLT2 surveillance, as well as some systemic imaging. And on one of those PET CTs, she was found to have a new lump on her back. So just kind of lateral to where the primary excision had been. And you can see that's that bright spot on the PET imaging. This was biopsied and confirmed to be melanoma. In this spot, this is something we can resect surgically. It's just there in the skin. There's lots of extra tissue there. But the question is whether surgery first is the right thing to be doing. And I think the things I've talked about so far have absolutely changed our clinical practice. In the last year and a half, this has probably been the biggest change for me as a surgeon when I'm seeing patients. And it really comes down to what is the role for neoadjuvant therapy for patients with melanoma. So I'm going to not look at Dr. Albertini and Dr. Ma as I explain the surgeon's view of immunotherapy. But the way I think about it is that melanoma is able to turn off the immune system right around it so that the immune system can't find it. And it does it because it doesn't allow certain things to bind, things like that. What the immunotherapies functionally do is they come in and they turn off that off switch. So now that the T cells, the immune system can start to be activated and fight the melanoma. The rationale about neoadjuvant therapy, as opposed to that's treatment before surgery, as opposed to only treatment after, is that if you get that immune system activated while the melanoma is still there, the immune system has a better chance of figuring out what it's supposed to be fighting and then maybe it's going to do a better job even after you remove it. So that's exactly what happened. And these are 2 studies that were published in the New England Journal. And so we can imagine anything published in the New England Journal means that this is going to be a big change in what we do. And they both looked at patients who got immunotherapy first, followed by surgery, plus or minus more immunotherapy after, versus surgery first and the same amount of immunotherapy after. The blue lines here are people who had neoadjuvant therapy. The red lines are the only immunotherapy after surgery, and you can see there's a marked difference in outcomes for patients who got the immunotherapy first. This has dramatically changed how we think about patients who come in with a spot like our case presentation, something that's surgically resectable, but maybe not as the first step. So just to summary what I talked about, I'm really excited about where we are with melanoma surgery because we're starting to think about how do we reduce the morbidity of what we do while making sure we still have good oncologic outcomes. So both Melmar-2 and MSLT2 exactly do that. They help to reduce the morbidity while making sure that we're not compromising any of our treatment. And we're really starting to leverage the innovations that we're seeing in systemic therapy, in immunotherapy, to optimize outcomes. So melanoma for the longest time was cut out anything you see always. And that's not where we are now. We're starting to really benefit from the systemic therapy advances and now starting to figure out how to sequence them to make sure that we're optimizing both the surgery and those systemic therapy pieces. I'm showing one picture from my recent vacation to remind you that even though you're all here this morning, it's really lovely outside. This is going to be a beautiful weekend. So I will pass this off to Dr. Ma, who's going to talk about some of the clinical studies that has helped with what I've talked about.